Okay, welcome back, everyone, from lunch. Last but not least, we have Dr. Dan Sherbenou, our excellent physician scientist. He is an avid Peloton cyclist, and he will share updates in myeloma.
Thank you, Lisa. Is that on? Sound good? We're good. Okay. Lisa, I'm going to be watching for you on Peloton now. We got a race. Um, okay. So, as you know, I do multiple myeloma here, and I'm going to be talking about multiple myeloma breakthroughs today. Is it on? Very good. Rachel told me how to do it, but I still messed it up. Okay. Um, so, as you know, I'm a multiple myeloma specialist here at the University of Colorado. Been here for many years, and today I'm going to be talking about multiple myeloma breakthroughs. And I have to tell you, as I was designing this talk on my way back on the plane from ASH, it occurred to me that just so much amazing stuff is happening in multiple myeloma. There's so many new drugs, and I kind of imagine them like superheroes. So there's a real comic book superhero theme to this talk, and that's basically from ChatGPT. I did not draw these. These were AI generated. So we'll jump right in. So these are the learning objectives today for my talk. So T cell redirecting therapies are really transforming myeloma care. If you didn't realize this, this is a multi-relapsing disease. It's generally considered incurable. People are diagnosed with active myeloma. We put them in remission with our therapies for multiple years, but ultimately, uniformly, they will relapse at some point. And as they go through their treatment trajectory, they will usually go through multiple different lines of therapy. So they progress to this relapse refractory state where we run out of therapies. Fortunately, today that really doesn't happen until people get maybe 12, 13 lines of therapy. We'd have so much available to us. So historically, IMiDs, PIs, monoclonal antibodies had really dominated for frontline multiple myeloma treatment in the early relapse setting. And we had reserved CAR T and bispecific antibodies, these T cell redirected therapies for lines greater than four. CAR T moved up about a year and a half ago to the second line. And now we really see bispecific antibodies doing the same. So that's really the main theme of this talk is how these new therapies are transforming how we treat relapsed myeloma and probably ultimately frontline myeloma as well. So there are lots of different ways to kill a multiple myeloma cell. These are antibody generating plasma cells that are susceptible to these immunomodulatory drugs, dexamethasone, proteasome inhibition. Of course, we got monoclonal antibodies, which are now very vital parts of frontline therapy as well. Then we have these T cell redirected therapies, and just to familiarize you with the names, we've got ide-cel, cilta-cel, teclistamab, talquetamab, elranatamab, and linvoseltamab. So this is your alphabet soup for today. We've got selinexor, venetoclax, belmaf as well with distinct mechanisms of action as well. And from really the ASH 2025 talks, I think the three main things to follow are that we are now getting bispecific combinations, which is new. We're seeing some data start to emerge on frontline T cell redirected therapies, and we're getting some new treatment for extramedullary disease. Been talking to a lot of people today, and it's evident there's a lot that I left out because there's so much in vivo CAR T, you name it, but this is kind of what fit into a 30-minute talk. You're really seeing these transplant and use of chemotherapy, saying the quiet part out loud, these are really going to go away with time. So it's pretty amazing. So our top myeloma abstracts, I'm going to approach these as kind of the earliest stage, which is smoldering myeloma. We'll talk about the Aquila trial with daratumumab, kind of reanalyzed with risk stratification that we more commonly use in clinic. Think about the maintenance setting, which is their Riga trial, addition of daratumumab to Revlimid as maintenance. A couple of frontline trials, the IFM 2021 with Daratec and the AZDO 120 CAR T in frontline. We'll talk about three early relapse trials with the Majestic 3, which is kind of if you've heard about ASH, what happened, if you probably heard about Majestic 3, this is kind of the golden child of ASH this year. magnetism 30 with iberdomide, and then antigamide and pomalidomide. And lastly, we'll finish up with the really pivotal abstract that was presented for extramedullary multiple myeloma with teclistamab and talquetamab. So when you think about these therapies, I explain this to patients. You're probably all familiar with how these work, but basically I say, these grab T cells with one arm and they grab the target myeloma cells with the other. They bring them together, they make the T cells angry, and they're very effective at killing myeloma cells. Talquetamab uses the GPRC5D target, whereas the others usually target BCMA, and there's several therapies that do that. So let's go to the first abstract, which I told you is going to be the Aquila trial. So this is the title of this one is daratumumab monotherapy versus active monitoring in patients with high-risk smoldering myeloma. The Aquila outcomes based on the Mayo 2018 IMWG 2020 risk stratification and the IMWG 2020 plus cytogenetic criteria and the age. So long title, but that's the topic. So this is a Aquila trial, of course, randomized phase 3 trial that got daratumumab approved, FDA approved in smoldering myeloma high risk. But on this trial, their high-risk smoldering myeloma criteria was not one that we generally use in clinical practice. This was very inclusive. All you had to have was a monoclonal protein, one of the following: monoclonal protein greater than 3, an IgA type, reduced uninvolved immunoglobulins, or free light chain ratio more than 8, or a bone marrow plasma cell greater than 50. And in that population overall, they saw a hazard ratio of 0.49, so a 51% reduction in the risk of myeloma progression or death. So this trial, this abstract, I should say, reanalyzed this with IMWG 2020 risk system. This is the validated system from Mayo 2018, so it's got a couple of different names. But basically, this is 3 different groups. Low risk have 0, intermediate have 1, and high risk have 2 risk factors of the ones listed here. So a little bit different than we just read, but bone marrow plasma cells greater than 20%, M spike more than 2, and a light chain ratio more than 20. You can see how patients, what their risk of progression is at 2 years and 5 years in this table. And so this is the way that it splayed out. Basically, what you see here is the high risk. See if I can. Well, I'll just show you the active high risk versus the DARA high risk really differentiated the most with a hazard ratio of 0.36, so much better than the overall population. Whereas intermediate are kind of in the middle, so there is still a benefit for intermediate. We're seeing the 60-month PFS rates at 56% compared to 42%, so still a pretty good difference there. Whereas the low risk, there's a more tightness of the curves, and we're not seeing nearly as much benefit in that group. Okay, I'm going to try and advance now. There we go. So this is what I use. This is basically the IMWG scoring system that also incorporates FISH abnormalities. This is not yet validated, but I think in general, we like to also think about that risk factor as well. This is a little bit more complicated. There are 4 different groups, and either low, intermediate, or high. And really, kind of the way this generally breaks down is that the 2 highest risk, or the kind of 4 more high risk that I showed you in the previous slide. So based on those 4 groups, not very many people in this the highest high risk group here. So a little bit harder to tell, but basically the low intermediate and the intermediate, the high risk, those people all benefited, where the low risk in this scoring system, the curves are overlapping. So there's not really any benefit for that particular group. So basically the curves favor daratumumab for this study. And, the bottom line is to treat people with high-risk smoldering myeloma, whichever system that you use, and consider for intermediate risk. For low risk, we need to observe those patients. All right, so next slide is just showing you that a couple other attributes of this abstract. There was no detrimental effect on stem cell collection. The overall survival is trending towards a benefit, but is currently immature. Safety, as there are treatment-related AEs versus the observation, of course, with some patients getting infections, really 10 to 27% across the different age groups versus 3 to 12%. But there's no new safety signals, nothing we didn't know about daratumumab. So I already told you the takeaway there. All right, so next setting, we're going to talk about the maintenance setting now. This is the AURIGA trial. The title is Minimal Residual Disease Dynamics in Post-Transplant Patients with Newly Diagnosed Myeloma who received daratumumab plus lenalidomide versus lenalidomide alone as maintenance therapy. All right, so the schematic is shown here. Basically, this is a phase 3 trial in anti-CD38 naive patients. This is key to note. Newly diagnosed patients that are MRD positive, so they're enrolled after they go through at least 4 cycles of induction, but are post-transplant and got transplant at least a year within the first year after they were diagnosed. They were randomized to either daratumumab and Revlimid or standard of care, which would be Revlimid alone. And I would say this is not the first time we've heard about AURIGA. We heard about it last year. There's a publication on this, but what's new is basically more follow-up and looking at sustained, basically the MRD dynamics and how those influence treatment. The primary endpoint was MRD conversion, and the secondary endpoints included the sustained MRD negative rate, et cetera, here. So the reason that I think this is important to mention is I do still see the situation occasionally where people come to me, they got induction that only included RVD, they didn't get daratumumab up front. And so this is how I convince their local oncologist or whoever is referring that you need to add daratumumab into their maintenance at that point, that there's still benefit for that. And second, I think that we really are getting more and more information, and this is one of the pieces about do we need to be doing doublet versus mono maintenance? And that's still an open question, and we'll be getting more data from that Perseus trial on that. But this is really kind of where we're trying to learn from this abstract. So it met its primary endpoint, MRD conversion rates with DR more than doubled compared to the Revlimid alone arm at both the 10 to the negative fifth, so 1 in 100,000, and the 10 to the negative sixth, the 1 in a million levels. So next part of this is that, well, interestingly, I just wanted to mention this is almost exactly from the Perseus. There was about a doubling to much higher rates when you don't get daratumumab up front than the Perseus trial, which included it right from the beginning, but still about the same rate of benefit between the two studies. So that's kind of notably reproducible. And then if we look at the sustained MRD negativity, there was a greater than 3.5-fold higher sustained MRD negative rate at 12 months and greater with DR at both the 10 to the negative fifth and even higher at the 10 to the negative sixth rate. So there weren't many people in the Revlimid arm that met that criteria. So I'm not going to say much about this PFS curve. If you didn't get daratumumab or an anti-CD38 antibody as part of your induction, there was definitely a benefit of adding that with a hazard ratio of 0.55. So that's concluded. So this is a little bit more interesting. So these are the patients that were either MRD negative and which arm that they were on. So you can see the people that reached MRD negativity that were on DR maintenance, they're doing fantastic. There's not many progression events at all in that group. There's not as many patients in that group that meet the MRD negative conversion criteria for Revlimid alone, but they generally do great too. They're seeing some late drop-offs there, a couple of late drop-offs, I should say, but that curve looks pretty decent as well. So MRD negativity, we know, is great. But on the other hand, there really wasn't much benefit for the people that stayed MRD positive, which not too surprising. So overall, the AURIGA data support the use of DR maintenance in clinical practice, although I will say, admit that it's a little bit hard to apply these data now, and all the patients should be getting an anti-CD38 antibody up front. So next we'll shift to the early relapse setting. This is, as I said, the golden child of ASH. teclistamab plus daratumumab as a frontline therapy. Excuse me, I've skipped to thinking about Majestic 3, but this is also cool. Teclistamab plus daratumumab is frontline therapy in transplant-ineligible patients with newly diagnosed myeloma, results from the IFM 2021-01 trial. So the study designed for this was a phase 2 trial with an all-antibody doublet in these transplant-ineligible folks that were newly diagnosed and greater than 65. So it ended up being that median age was 73, 14% were ISS3, and 32% had high risk, which is all fairly typical. So in this study, there are actually two cohorts, Dara-Tech and Tech-Len. We're just hearing about the Dara-Tech in this abstract. So these are the results. Really, pretty impressive overall response rate of 100%. The primary endpoint was met that 79% of patients were VGPR or better after 4 cycles. 100% of patients reached a VGPR overall. There was a 100% MRD negative rate at 10 to the negative sixth. But just in the evaluable patients, you can see that in this table, there are some of these patients that were that for different reasons had test failures or missing samples, but notably no patients were MRD positive on this study. Really interesting to think about from a scientific standpoint, the T cell dynamics of targeting CD38 simultaneously with the T cell engaging therapy. CD38 is present on some T cells, particularly when they're activated, but that ended up appearing to be pretty positive overall for patients. So as you can see from these PFS and OS curves, they're perfect. A small group of patients, but no one has relapsed. So we'd like to see that curve. That's amazing. Only 10.3 months of follow-up so far, so still early, but exciting data so far. Side effects to know about. So we do see a high rate of lymphopenia, neutropenia. Most patients had CRS, but these are only grade 1 and grade 2, nothing high grade. No ICANS at all in the study, which is great. Infection control in this study was that they did systemically use IVIG for all patients, and there was a low overall severe infection rate of 14%, which is kind of similar to most myeloma therapies, I would say. So the key message from this trial is that there's an all-antibody frontline doublet that induces deep, rapid, potentially durable responses in newly diagnosed patients without a transplant. As I mentioned, maybe that goes away with stuff like this and really sets the ground for doing this in larger phase 3 randomized studies. All right, so I'll mention kind of rapidly the next two. So we have a dual targeting BCMA and CD19 fast CAR in first-line therapy is newly diagnosed patients. So this is an AstraZeneca bispecific CAR. And the study design for this is a phase 1/2 study with this fast CAR that's generated in a they didn't actually say how fast, but it's generally a pretty quick process. There were overall 30 patients. The median age was 64, and 48% had high risk, although that did include 1Q gain. Rapid manufacturing led to the ability of diagnosis to infusion times of about 3 months, supporting this feasibility in this setting. And you can see here on the study schematic that this was actually an abstract presenting both transplant-ineligible and transplant-eligible studies meshed together to bring up the N to a reasonable number. And that patients were permitted to get up to 2 cycles of RVD, lenalidomide, bortezomib, dexamethasone before or after apheresis. So they did get the double whammy approach there. And then also notably on this trial, people were allowed to go on lenalidomide maintenance. So again, really great curves here. We got an overall response rate of 100%, stringent CR rate of 97%, MRD negative at 10 to the negative sixth was 100% among evaluable patients. You can see the group here is 30 patients initially, and then responses deepened over time, but actually kind of lost a couple of patients to progression. The PFS curve looks pretty good, but a couple of people died, with 3 being attributable to progressive disease, which really shouldn't happen, but I don't think that's related to the drug necessarily, maybe access or other issues. But anyway, this is also really promising frontline to take CAR T into. A little bit more explanation about how that's sussed out in terms of people that had sustained MRD negative on the study, which would be the green curves on these plots. Patients were 100% progression free throughout the pretty reasonable number of months on study. The people that were not sustaining MRD negativity was an early sign that they were going to relapse clinically. So really, this implies that this CAR T is a good transplant alternative to be tested in further trials in the coming years. All right, so back to the Majestic-3 trial, which I tried to introduce in a minute ago. So this is a phase 3 randomized study of teclistamab plus daratumumab versus investigators' choice of daratumumab and dexamethasone with either pomalidomide or bortezomib. So that's DPD or DVD in patients with relapsed refractory myeloma. This is also available in the New England Journal of Medicine, Costa and colleagues. So this is a schematic. This is a phase 3 early relapse, so the 1 to 3 prior line setting, a total of 587 patients that were randomized. The responses were higher with Tecdara by an overall response rate of 89% versus 75%, stringent CR of 77 versus 23%. The MRD negative was even more astoundingly better. The 10 to negative fifth, it was 58% versus 17%, and at 10 to the negative sixth, 28 versus 7%. The primary endpoint was met that Tecdara was superior with a hazard ratio of a whopping 0.17, median PFS not reached versus 18 months. And across subgroups, there was uniform benefit, even in high risk cytogenetics. And notably, I maybe skipped over this in mentioning it in the last slide, but these patients had not received a CD38 antibody up front, so they're seeing DARA for the first time. But for the most part, but there are 5% that had been exposed but weren't refractory, and those that should say DARA exposed, not refractory. Sorry for the typo. Those patients did equally as well as the whole group. And so this is how the dosing schedule works, just for your information, that the initial ramp-up period over a week with daratumumab and teclistamab, and then teclistamab goes to weekly with the daratumumab during cycle 2, and then every other week, cycles 3 to 6, and then continues with monthly daratumumab thereafter. And this is the PFS curve. So this is really kind of astounding data where almost 85% of patients were relapse-free at 3 years compared to only 29% in our standard of care DPD, DVD. So these triplets based on anti-CD38 antibody therapy. So it really supports earlier line bispecific use. Also, the overall survival curve is glued in here as well, where you can see there it's a little bit less mature, but still kind of a clear benefit towards overall survival from the teclistamab daratumumab arm. So although this wasn't compared directly with CAR T, these are our best efficacy data in the 1 to 3 prior line setting period, with the caveat being, again, that these are patients that were not daratumumab refractory. So this is from the supplemental data from the New England Journal of Medicine paper that I just think is kind of fascinating. And you saw some patients die of infections, especially early on. And these are related to COVID by the solid green dots for the DARA tech arm versus the solid red for the control arm. So they're having a lot more infection and COVID-related deaths. And this is graphed on top of the global pandemic numbers for COVID. So this trial really started during the COVID pandemic. And then when that kind of came to a conclusion and we started, doing this IVIG and everyone approach, you really see these infections, become a much more reasonable number. So I think the numbers would even have looked better if this had been done with IVIG approach. So overall, there were more cytopenias and infections with Tecdara. Grade 3 and 4 infection rate was 32% higher than we would like versus 18%, which is more typical. And then CRS was, again, mostly grade 1 and 2 without much ICANS at all. All right, so a couple of quick hits now. Etentamig plus pomalidomide and dexamethasone in relapsed refractory patients, a dose escalation and safety expansion study called Kilimanjaro. Study design was a phase 1b. 51% of patients in this study were pomalidomide refractory. There are two arms being tested here and put and meshed together. So we have pomalidomide being lenalidomide exposure being required and pomalidomide refractoriness being allowed in both of those arms. And arm A was the earlier one, so the later line, and then arm E was the earlier 1 to 3 lines. And so this is a little bit earlier than the Majestic 3 data, but similarly pretty good response rates in the 81% to 83% range. So good efficacy, good depth, 75% being MRD negative of the 10 to the negative fifth. And so far, the durability with median follow-up of 23 months, median PFS and DOR were not reached, and 76% were relapse-free at 18 months. So I'm going to go ahead and skip this due to time. And so similar abstract to safety and efficacy of elranatamab in combination with iberdomide now, so a CELMoD in patients with relapsed refractory myeloma, the Magnetism 30 trial. And so this basically was a phase 1b in the 2 to 4 prior lines of setting of another BCMA bispecific, this time with the CELMoD. Heavily pretreated population for this one. And here's the schematic. So they initially started with a possibility to go up or down in the dose. Elranatamab was given weekly. They chose to go down to the 2 weekly dose, and that ended up being what they're evaluating in an ongoing manner. So 8 patients were on the dose level 1 from this report, and 9% from the other. So as we look at the overall efficacy, this also is impressive response rate of 95% with a CR rate of 45%, rapid responses, good activity, even in extramedullary disease. And so this is looking to move forward as well. So infections were a similar theme here. We're still early in the durability, but we are seeing a fair amount of neutropenia, 14% in grade 3, and about the same infections as the other studies. So now the redirect study with talquetamab and teclistamab in patients with relapsed myeloma that have extramedullary disease. This is also in the New England Journal of Medicine published simultaneously to the abstract presentation by Shaji Kumar and colleagues. So extramedullary disease is a highly unmet need in multiple myeloma. This study was unique because it was a phase 2 study where they're just enrolling patients with true extramedullary disease, and sometimes it's hard in other studies prior to this to really see if it was true AMD and not people that had potentially bone lesions that had grown out into the soft tissue areas, so true soft tissue disease that had become microenvironment independent. 5 prior lines for this study, and really this is kind of showing what we had learned from GPRC5D BCMA bispecific targeting in previous studies, that this works quite well. Overall, 90 evaluable patients in this study. And so really good response rate for this hard population, 80%, among the highest that we've seen in this setting. Good depth of response and durability with 60% progression-free at 12 months. So this patient's still high risk, but at least we're giving them a little bit more than a year for the most part here. And we're adding on the GPRC5D toxicities of skin, nail, taste, but overall, worthwhile activity to take on that risk. So I'm going to finish up on the next couple of slides, just talking a little bit about sequencing therapy in 2026. How does this change our paradigm? And thinking about all the different possibilities that you can walk through. I think that most of my patients, at least personally, are going to be off of daratumumab by the time they relapse and need second-line therapy. So I think they fit well into this dara teclistamab bucket, and Carvykti, after really being my go-to in second line just 3 months ago, has totally switched, and now it's kind of maybe a third line or a fourth line treatment after they relapse after Daratec. So that's really shifted. Um, and I think different myeloma physicians are going to approach this differently. Of course, in third line, we need to figure out exactly what's optimal. Can we go back to back with a bispecific antibody to a CAR T that also targets BCMA, or do we need to give them a break and try something like selinexor or KPD? And then, people keep relapsing. We come back to another line of therapy, and ultimately it's maybe fifth line where we're really needing clinical trials, further development, and thinking about retreatment and how to guide that. I think one point I wanted to really drive home on is that in our lab, we measure drug sensitivity, and this is kind of a preclinical tool right now, but ultimately measuring drug sensitivity, personalizing medicine. Our pathology lab will now measure BCMA levels so we can see when patients lose the expression of this target, which after we're hitting it over and over again is bound to happen. And I have patients that are suffering from that already. And then ultimately, I think we need to do mutation profiling similar to our AML colleagues to really understand when people get drug resistance mutations in BCMA or GPRC5D at all of these different treatment decision points. So clinical trials currently open that are open at our plasma cell program. We're really excited about this Caribou study, which is an allogeneic CAR T. So I've got a new character. He is BCMA CAR T cell, but he's kind of invisible. I'll tell you why in a minute. We've got the Durga-1 study, which is this AZD0120 that Dr. Monhe just opened for patients in this setting as well. So this is kind of like the 3 prior lines setting. And then we've got Majestic 4 that's about to open. The next one in the Majestic series, basically, that looks at teclistamab versus Revlimid in the maintenance setting versus both. So it's got 3 arms. So that's a really exciting study that Dr. Monhe is opening as well. And then a lot of stuff in our pipeline. We're going to be opening something in smoldering soon. Very excited about that, and filling this hole in the earlier relapse setting before the 3 or more prior lines that the Durga-1 and Caribou studies cover, and more to come in this group as well. So moving past ASH highlights, this is actually a tandem highlight. The Caribou study was reported at the tandem meeting. Was it last week or the week before? Basically, this is on CB11 allogeneic BCMA CAR T cell therapy with immune cloaking for patients with relapsed refractory myeloma, which is also called the Camouflage-1 trial. And I'm just going to say that this is probably the coolest thing you're going to hear about today. I am biased because I do myeloma and I'm a scientist, but this is super cool. So it's basically a CAR T cell that's had immune editing with CRISPR on 3 different levels. So on the kind of basic level, it gets the anti-BCMA CAR. It has the T cell receptor that's native is knocked out. They also do a beta 2 microglobulin gene knockout to slow down T cell mediated rejection of these allograft cells. They remove the HLA class 1 surface expression, and they to mimic a partial match, HLA match. And it's really designed to try and get these allogeneic cells to evade the immune system and do their work for a long enough period of time. And so the design of this trial is in 3 or more prior lines of therapy, as I'll tell you. This is most of the patients that I'll tell you about, I think actually all of them were BCMA naive, but now it's enrolling patients that have BCMA exposures in the past, either CAR T, ADCs, or bispecifics. The results, the dose level that we escalated to that worked well was 500 of Cy and 30 of flu for 3 days, and 450 million CAR T cells from the donors. So it's an off-the-shelf product. And these are the results so far. So this is obviously still maturing, and really the tandem presentation was our first announcement of this, but this does induce deep and durable responses at the recommended dose expansion level that I just told you, 92% overall response rate with 75% getting at least a CR or better, 91% getting MRD negative. So far, we have lost a couple of people to progression in the kind of less than a year standpoint, but we're still waiting on exactly how durable this is going to be. But pretty excited about this one. Just to show you the safety as we did for the others, we do have kind of some of the same issues of having infections between 14 and 25%. In particular, we had some ICAT, so some prolonged cytopenias on this one, but notably no GVHD, which you would really be watching out for. So they successfully mitigated that risk with their knockouts. There was no Parkinsonism. There were no cranial nerve palsies at any of the dose levels. So with that, I'm going to thank all of you and, give some props to my fellow superheroes in our clinic, nurses, pharmacists, nurse practitioners, and PAs. Really been great to have your attention, and happy Valentine's Day. Go home to your sweethearts. Thank you.